Acute Coronary Syndrome, Chapter 34 of the Lewis textbook. This is a review from class. When ischemia is prolonged and not immediately reversible, acute coronary syndrome, ACS, develops and encompasses a spectrum of unstable angina, non-ST segment elevation myocardial infarction, an NSTEMI, and ST segment elevation myocardial infarction, a STEMI. ACS is associated with deterioration of a once stable atherosclerotic plaque that ruptures, exposing the intima to blood and stimulating platelet aggregation and local vasoconstriction with thrombus formation. This unstable lesion may be partially occluded by a thrombus, which symptoms would show as unstable angina or NSTEMI, or totally occluded by a thrombus as in a STEMI. Patients with suspected ACS require immediate hospitalization. Unstable angina is chest pain that is new in onset, occurs at rest, or has a worsening pattern. A patient with chronic stable angina may develop unstable angina, or it may be the first clinical sign of coronary artery disease. The patient with previously diagnosed chronic stable angina will describe a significant change in the pattern of the pain. It will occur with increasing frequency and easily provoked by minimal or no exertion during sleep or even at rest. Unlike chronic stable angina, unstable angina is unpredictable and is an emergency. Despite national efforts to increase awareness, women's symptoms continue to go unrecognized as heart-related. These include fatigue, shortness of breath, indigestion, and anxiety. Fatigue is the most prominent symptom, but all of these symptoms can relate to many other different diseases, and it's because of these reasons that women often present with unstable angina before coronary artery disease is diagnosed. A myocardial infarction occurs because sustained ischemia causing an irreversible myocardial cell death, necrosis. Thrombus formation causes 80 to 90% of all acute MIs. When a thrombus develops, blood to the myocardium distal to the blockages halt, resulting in necrosis. The acute MI process takes time. Cardiac cells can withstand ischemic conditions for approximately 20 minutes before cellular death begins. The earliest tissue to become ischemic is the subendocardium, the innermost layer of tissue in the cardiac muscle. If ischemia persists, it takes approximately 4 to 6 hours for the entire thickness of the muscle to become necrosed. If the thrombus is not completely blocking the artery, the time to complete necrosis may be as long as 12 hours. Contractile function of the heart stops in the necrotic areas. The degree of altered function depends on the area of the heart involved and the size of the infarction. MIs are usually described on the location of damage, like anterior, inferior, lateral, septal, or posterior wall infarction. Most involve some portion of the left ventricle. The location of the infarction correlates with the involved coronary circulation. So, for example, the right coronary artery provides blood supply to the inferior wall. Blockage of the right coronary artery would result in an inferior wall MI. Anterior wall infarctions result from blockages in the left anterior descending artery. Blockages in the left circumflex artery usually cause lateral and/or posterior wall MIs. Damage can occur in more than one location, especially if more than one coronary artery is involved, like anterolateral MI or anteroseptal MI. The degree of pre-existing collateral circulation also influences the severity of the infarction. An individual with a long history of coronary artery disease will develop collateral circulation to provide the area surrounding the infarction site with a blood supply. This is one reason why a younger person may have a more serious MI than someone who's older with the same degree of blockage. Several immobilizing chest pains may not be relieved by rest, position, change, or nitrate administration, and this is the hallmark of an MI. It is persistent and unlike any other pain. It is usually described as heaviness, pressure, tightness, burning, constriction, or crushing. Common locations are substernal, retrosternal, or epigastric areas. When epigastric pain is present, the patient may relate to it as indigestion and take antacids without relief. The pain may radiate to the neck, lower jaw, and arms, or to the back, and it may occur while the patient is active or at rest, asleep, or awake. However, it commonly occurs in the early morning hours and usually lasts for 20 minutes or longer and is more severe than usual anginal pain. Not everyone has classic symptoms. Some patients may not experience pain but may have discomfort or weakness or shortness of breath. Although women and men have more similarities in their symptoms of an acute MI than differences, some women may experience atypical discomfort, shortness of breath, or fatigue. In response to the release of catecholamines, the blood pressure and heart rate may initially increase. The blood pressure may later drop because of decreased cardiac output. If severe enough, this results in decreased renal perfusion and decreased urine output. Crackles, if present, may persist for several hours to several days, suggesting left ventricular dysfunction. Jugular venous distension, hepatic engorgement, and peripheral edema may indicate right ventricular dysfunction. Cardiac examination may reveal abnormal heart sounds that may seem distant. Other abnormal sounds suggesting ventricular dysfunction are S3 and S4. In addition, a loud holosystolic murmur may develop and could indicate a septal defect, a papillary muscle rupture, or valve dysfunction. The patient may experience nausea and vomiting. These symptoms can result from reflex stimulation of the vomiting center by the severe pain. They can also result from vasovagal reflexes initiated from the area of the infarcted myocardium. The temperature elevation may last for as long as a week, and this increase in temperature is due to systemic inflammatory process caused by myocardial cell death. The body's response to cell death is the inflammatory process. Within 24 hours, leukocytes infiltrate the area of cell death. The proteolytic enzymes of the neutrophils and macrophages begin to remove necrotic tissue by the 4th day. During this time, the necrotic muscle wall is thin. The necrotic zone is identifiable by ECG changes like ST segment elevation, pathological Q wave, and by nuclear scanning after the onset of symptoms. At this point, the neutrophils and monocytes have cleared the necrotic debris from the injured area, and the collagen matrix that will eventually form scar tissue is laid down. At 10 to 14 days after an MI, the new scar tissue is still weak, and the myocardium is vulnerable to increased stress during this time because of the unstable state of the healing heart wall. It is also at this time that the patient's activity level may be increasing, so special caution and assessment are necessary. By week 6 after an MI, scar tissue has replaced necrotic tissue, and the injured area is considered healed. The scar area is often less compliant than the surrounding area. This condition can be manifested by uncoordinated wall motion, ventricular dysfunction, altered conduction patterns, or heart failure. And these changes in the infarcted muscle also cause changes in the unaffected myocardium. In an attempt to compensate for that damaged muscle, the normal myocardium will hypertrophy and dilate. This process is called ventricular remodeling, and remodeling of normal myocardium can lead to the development of late heart failure, especially in an individual with atherosclerosis of other coronary arteries and/or an anterior MI. The most common complication after an MI is dysrhythmias, which are present in 80 to 90% of patients. Dysrhythmias are the most common cause of death in patients in the pre-hospital period. Life-threatening dysrhythmias occurs most often with an anterior wall infarction, heart failure, or shock. Complete heart block develops when key portions of the conduction system are destroyed. Ventricular fibrillation, a common cause of sudden cardiac death, is a lethal dysrhythmia. It most often occurs within the first 4 hours after the onset of pain. Premature ventricular contractions may precede ventricular tachycardia and fibrillation. Life-threatening ventricular dysrhythmias must be treated immediately. Heart failure is a complication that occurs when the pumping action of the heart is reduced. Depending on the severity and extent of the injury, heart failure occurs initially with subtle signs like mild dyspnea, restlessness, agitation, or slight tachycardia. Other signs indicating the onset of heart failure include pulmonary congestion on chest X-ray, S3 or S4 heart sounds on auscultation, crackles on auscultation of breath sounds, and jugular vein distension. Cardiogenic shock occurs when oxygen and nutrients supplied to the tissues are inadequate because of severe left ventricular failure. This occurs less often with the early and rapid treatment of MI with PCI or thrombolytic therapy. When cardiogenic shock does occur, it has a high mortality rate. And cardiogenic shock requires aggressive management, and this includes control of dysrhythmias, intra-aortic balloon pump therapy, and support of contractility with the use of vasoactive drugs. The goal of therapy is to maximize oxygen delivery, reduce oxygen demand, and prevent complications such as acute renal failure. Papillary muscle dysfunction may occur if the infarcted area includes or is near the papillary muscle that attaches to the mitral valve. The papillary muscle rupture is a rare and life-threatening complication and causes massive mitral valve regurgitation. Symptoms are dyspnea, pulmonary edema, and decreased cardiac output result from the backup of blood in the left atrium. This condition aggravates an already damaged left ventricle by reducing cardiac output even further. There is rapid clinical deterioration of the patient, and treatment includes rapid afterload reduction with nitroprusside, intra-aortic balloon pump therapy, and immediate cardiac surgery with mitral valve repair or replacement. Ventricular aneurysm results from an infarcted myocardial wall that is thin and bulges out during contractions. This can develop over a few days, weeks, or months. The patient with a ventricular aneurysm may experience heart failure, dysrhythmias, and angina. Besides ventricular rupture, which is fatal, ventricular aneurysms harbor thrombi that can lead to an embolic stroke. Pericarditis is an inflammation of the visceral and/or parietal pericardium, and it may result in cardiac tamponade, decreased ventricular filling, and emptying and heart failure. It occurs 2 to 3 days after an acute MI as a common complication of the infarction. Chest pain may vary from mild to severe and is aggravated by inspiration, coughing, and movement of the upper body, which are characteristic of pericarditis. Sitting in a forward position often relieves the pain. Assess the patient if you suspect pericarditis for the presence of a friction rub over the pericardium. Fever may also be present. There may be hypotension or a narrow pulse pressure associated with the decreased left ventricular filling and emptying. Diagnosis of pericarditis can be made with serial 12-lead ECGs. Typical ECG changes include diffuse ST segment elevations. This reflects the inflammation to the pericardium. Treatment includes pain relief with nonsteroidals, aspirin, or corticosteroids. Dressler syndrome is pericarditis with effusion and fever that develops 4 to 6 weeks after an MI. It is thought to be caused by an antigen-antibody reaction to the necrotic myocardium. The patient experiences pericardial pain, fever, a friction rub, pericardial effusion, and arthralgia. Lab findings include an elevated white blood cell count and sedimentation rate. Short-term corticosteroids are used to treat this condition. The ECG is one of the primary diagnostic tools. Changes in the QRS complex, ST segment, and T wave caused by ischemia and infarction can develop quickly with unstable angina and MI. For diagnostic and treatment purposes, it is important to distinguish between STEMI and unstable angina or NSTEMI. Patients with the STEMI tend to have a more extensive MI that is associated with prolonged and complete coronary occlusion and the development of a pathological Q wave on the ECG. Patients with unstable angina or NSTEMI usually have transient thrombosis or incomplete coronary occlusion and usually do not develop pathological Q waves. Because MI is a dynamic process that evolves with time, the ECG often reveals the time sequence of ischemia, injury, infarction, and resolution of the infarction. Within a few hours, the ECG may change to reflect the infarction process. For this reason, when the initial 12-lead ECG is non-diagnostic, serial 12-lead ECGs are done. Coronary angiography. A patient with unstable angina or NSTEMI may or may not undergo coronary angiography to evaluate the extent of the disease. Guidelines suggest that it's reasonable to do a coronary angiography on stable but high-risk patients with unstable angina and NSTEMI. If appropriate, a PCI is performed at this time, and patients may be treated with conservative medical management. Coronary angio is the only way to confirm the diagnosis of princemental angina. Exercise or pharmacological stress testing and echocardiogram are used when a patient has an abnormal but non-diagnostic baseline ECG. A dobutamine, a dipyridamole, or adenosine stress echocardiogram stimulates the effects of exercise and is used in patients unable to exercise. Serum cardiac markers are proteins released into the blood from necrotic heart muscle after an MI. Cardiac-specific troponin has 2 subtypes: cardiac-specific troponin T and cardiac-specific troponin I. These markers are highly specific indicators of MI and have greater sensitivity and specificity for myocardial injury than creatinine kinase CK-MB. Serum levels of cardiac-specific troponin T and I increase 4 to 6 hours after the onset of an MI, peak at 10 to 24 hours, and return to baseline over 10 to 14 days. CK levels begin to rise at about 6 hours after an MI, peak at about 18 hours, and return to normal within 24 to 36 hours. The CK enzymes are fractionated into bands. The CK-MB band is specific to myocardial cells and also helps quantify myocardial damage. Myoglobin is released into the circulation within 2 hours after an MI and peaks in 3 to 15 hours. Although it is one of the first serum cardiac markers to appear after an MI, it lacks cardiac specificity. Its role in diagnosing an MI is limited. It is extremely important to rapidly diagnose and treat a patient with acute coronary syndrome to preserve cardiac muscle. Obtain a 12-lead ECG and start continuous ECG monitoring. Position a patient in an upright position unless contraindicated and initiate oxygen by nasal cannula to keep oxygen saturation above 93%. Establish an IV route to provide access for emergency drug therapy. Give sublingual nitroglycerin and aspirin, chewable, if not given before arrival at the emergency department. Morphine sulfate is given for pain unrelieved by nitroglycerin. The patient will usually receive ongoing care in the critical care unit or telemetry unit where continuous ECG monitoring is available. Dysrhythmias are treated according to established protocols. Monitor vital signs, including pulse oximetry, and frequently during the first few hours after admission and closely after that. Maintain bed rest and limitation of activity for 12 to 24 hours with a gradual increase in activity unless contraindicated. For patients with unstable angina or NSTEMI with negative cardiac monitors and ongoing angina, then a combination of aspirin, heparin, and glycoprotein inhibitors is recommended. Coronary angiography with possible PCI is considered once the patient is stabilized and angina is controlled, or if angina returns or increases in severity. Priority interventions are aimed at decreasing the oxygen needs of a compromised myocardium and reducing the risk of complications, providing nitroglycerin, morphine sulfate, and supplemental oxygen as needed to eliminate or reduce the chest pain. Maintain continuous ECG monitoring while in the emergency department and intensive care unit and after transfer to a step-down or general unit. Dysrhythmias need to be identified quickly and treated because during the initial period after an MI, ventricular fibrillation is the most common lethal dysrhythmia. In many patients, premature ventricular contractions or ventricular tachycardia precede this dysrhythmia. Monitor the patient for the presence of reinfarction or ischemia by monitoring the ST segment for shifts above or below the baseline of the ECG. It is important to promote rest and comfort with any degree of myocardial injury. Bed rest may be ordered for the first few days after an MI involving a large portion of the ventricle. A patient with an uncomplicated MI, like angina resolved and no signs of complication, may rest in a chair within 8 to 12 hours after the event. The use of a commode or bedpan is based on patient preference. When sleeping or resting, the body requires less work from the heart than it does when it's active, and anxiety is present in all patients with ACS to some degree. The role of the nurse is to identify the source of anxiety and assist the patient in reducing it. If the patient is afraid of being alone, allow a caregiver to sit by quietly or check with the patient frequently. For anxiety caused by lack of information, provide teaching based on the patient's stated need and level of understanding. Answer the patient's questions with clear, simple explanations. Frequently, the patient may not be able to ask the most serious concern of ACS, which is, am I going to die? Even if a patient denies this concern, it is helpful for you to start conversations by remarking that fear of dying is a common concern among most patients who have experienced acute coronary syndrome, and this gives the patient permission to talk about an uncomfortable and fearful topic. Open visitation is helpful in decreasing anxiety and increasing support for a patient with ACS. For patients with STEMI or NSTEMI with positive cardiac markers, reperfusion therapy is initiated. Reperfusion therapy can include emergent PCI for STEMI and NSTEMI, or thrombolytic fibrolytic therapy for STEMI. The goal in the treatment of MI is to salvage as much myocardial muscle as possible. Emergent PCI is the first line of treatment for patients with confirmed MI, a definitive ECG change, and or positive cardiac markers. The goal is to open the blocked artery within 90 minutes of arrival to a facility that has an interventional cardiac catheterization laboratory. In this situation, the patient will undergo a cardiac catheterization to locate the blockages, assess the severity of the blockages, determine the presence of collateral circulation, and evaluate left ventricular function. During the procedure, treatment modalities like placement of drug-eluting stents are selected. Patients with severe left ventricular dysfunction may require the addition of an intra-aortic balloon pump therapy, and a small percentage of patients may require emergent coronary artery bypass graft surgery. The advantages of PCI include the following. It provides an alternative to surgical intervention. It is performed with local anesthesia. The patient is ambulatory shortly after the procedure. The length of hospital stay is approximately 1 to 3 days, compared with the 4 to 6 days with coronary artery bypass surgery. The 1 to 3 days reduces hospital costs, and the patient can return to work several weeks sooner after a PCI compared to 6 to 8 week convalescence after a coronary artery bypass graft. Advances in PCI techniques have significantly reduced the need for emergent bypass grafts. Currently, there are more PCIs performed than the grafts. Thrombolytic therapy offers the advantage of availability and rapid administration in facilities that do not have an interventional cardiac catheterization laboratory or one is too far away to transfer the patient safely. Treatment of MI with thrombolytic therapy aims to stop the infarction process by dissolving the thrombus in the coronary artery and reperfusing the myocardium. Thrombolytic therapy is given as soon as possible, ideally within the first hour after onset of symptoms and preferably within the first 6 hours after the onset of symptoms. Mortality is reduced by 25% if reperfusion occurs within 6 hours. All thrombolytics are given IV. Patient selection is important because minor or major bleeding can be a complication of the therapy. Inclusion criteria for thrombolytic therapy include chest pain typical of acute MI, 6 hours or less, 12-lead ECG findings consistent with an acute MI, and no absolute contraindications. Each hospital has a protocol for giving thrombolytic therapy. Draw blood to obtain baseline lab values and start 2 or 3 lines for IV therapy. All other invasive procedures are done before the thrombolytic agent is given to reduce the possibility of bleeding in the patient. Depending on the drug selected, therapy is administered in 1 IV bolus or over a period of time like 30 to 90 minutes. Evaluate the heart rhythm. What are the vital signs? Pulse ox. And assess the heart and lungs frequently to evaluate the patient's response to the therapy. Regularly assess for changes in neurological status, as this may indicate a cerebral bleed. When reperfusion occurs, the coronary artery that was blocked is open and blood flow is restored to the myocardium, and several clinical markers may occur. The most reliable marker is the return of the ST segment to baseline on the ECG. Other markers include a resolution of chest pain and an early rapid rise of the cardiac markers within 3 hours of the therapy and peaking within 12 hours. These levels increase as the necrotic myocardial cells release proteins into the circulation after perfusion is restored to the area. The presence of reperfusion dysrhythmias, like an accelerated idioventricular rhythm, is a less reliable marker of reperfusion. These dysrhythmias are generally self-limiting and do not require aggressive treatment. A major concern with thrombolytic therapy is reocclusion of the artery. The site of the thrombus could be unstable and another clot may form or spasm of the artery might occur. Because of this possibility, IV heparin therapy is initiated. Coronary revascularization with coronary artery bypass graft, a CABG, is recommended for patients who fail medical management, have left main coronary artery or 3-vessel disease, are not candidates for PCI because the lesions are long or difficult to access, have failed PCI and continue to have chest pain, have diabetes mellitus, or when long-term benefits of CABG are superior to those of a PCI. CABG surgery consists of the placement of conduits to transport blood between the aorta or other major arteries and the myocardium distal to the blocked coronary artery or arteries. CABG surgery requires a sternotomy, which is an opening of the chest cavity, and cardiopulmonary bypass. This procedure may involve one or more grafts using the internal mammary artery, saphenous vein, radial artery, gastroepiloic artery, and/or inferior epigastric artery. Minimally invasive direct coronary artery bypass graft is a technique that offers patients with limited disease an approach to surgical treatment that does not involve a sternotomy and cardiac bypass. This technique requires several small incisions between the ribs. A thoracoscope is used to dissect the internal mammary artery. The heart is slowed using beta-adrenergic blockers like esmolol or stopped temporarily with adenosine. A mechanical stabilizer immobilizes the operative site. During cardiopulmonary bypass, blood is diverted from the patient's heart to a machine where it is oxygenated and returned via the pump to the patient. This allows the surgeon to operate on a quiet, non-beating, bloodless heart while perfusion to vital organs is maintained. For patients having CABG surgery, care is provided in the intensive care unit for the first 24 to 36 hours. Ongoing and intensive monitoring of the patient's hemodynamic status is critical. The patient will have numerous invasive lines for monitoring cardiac status and other vital organs. These include a pulmonary artery catheter for measuring cardiac output and other hemodynamic parameters, an intra-arterial line for continuous blood pressure monitoring, pleural and mediastinal chest tubes for chest drainage, continuous ECG monitoring to detect arrhythmias, an endotracheal tube connected to mechanical ventilation, epicardial pacing wires for emergency pacing of the heart, a urinary catheter to monitor urine output, a nasogastric tube for gastric decompression. Most patients will be extubated within 6 hours and transferred to a step-down unit within 24 hours for continued monitoring of cardiac status. Many of the post-operative complications that develop after CABG surgery relate to the use of cardiopulmonary bypass. Major consequences of cardiopulmonary bypass are systemic inflammation, which includes complications of bleeding and anemia from damage to red blood cells and platelets, fluid and electrolyte imbalances, and hypothermia as blood is cooled as it passes through the cardiopulmonary bypass machine, and possible infections. The internal mammary artery is the most common artery used for bypass graft. It is left attached to its origin, the subclavian artery, but then dissected from the chest wall. Next, it is anastomosed, connected with sutures to the coronary artery distal to the blockage. The long-term patency rate for internal mammary artery grafts is greater than 90% after 10 years. Saphenous veins are also used for bypass grafts. The surgeon removes the saphenous vein from one or both legs endoscopically. Sections are attached to the ascending aorta and then to the coronary artery distal to the blockage. The use of antiplatelet therapy and statins after surgery improves vein graft patency. Patency rates of these grafts are 50 to 60% at 10 years. Other conduits include the gastroepiloic or inferior epigastric artery, but these are rarely used as the dissection of these arteries is extensive. This increases the length of the surgery and the risk for wound complications at the harvest site, especially in an obese or diabetic patient. The off-pump coronary bypass procedure uses full or partial sternotomy to access all coronary vessels. It is performed on a beating heart using mechanical stabilizers and without cardiopulmonary bypass. It is usually reserved for patients with limited disease but who are at high risk for traditional surgery secondary to multiple comorbidities. Robot-assisted cardiothoracic surgery incorporates the use of a robot in performing a CABG or mitral valve replacement. The benefits of robotic surgery include increased precision, smaller incisions, decreased blood loss, less pain, and shorter recovery time. Transmyocardial laser revascularization is an indirect revascularization procedure. It is used for patients with advanced coronary artery disease who are not candidates for traditional CABG surgery and who have a persistent angina after maximal medical therapy. The procedure involves the use of high-energy laser to create channels in the heart to allow blood flow to ischemic areas. The procedures performed during cardiac catheterization as a percutaneous transmyocardial laser revascularization or during surgery using a left anterior thoracotomy incision as an adjunct to the CABG. Patients with ACS may undergo coronary revascularization with percutaneous coronary intervention or CABG surgery. The major nursing responsibilities for the care of the patient following a PCI include monitoring for signs of recurrent angina, frequent assessment of vital signs including heart rate and rhythm, evaluation of the catheter insertion site for signs of bleeding, neurovascular assessment of the involved extremity, and maintenance of bed rest per institution policy. CABG postoperative nursing care. Assess the patient for bleeding. Check for chest tube drainage and incision sites. Check fluid status, replace electrolytes, restore the temperature with warming blankets if needed. Postoperative dysrhythmias, specifically atrial dysrhythmias, are common in the first 3 days after CABG surgery. Postoperative atrial fibrillation occurs in 20 to 50% of patients. Nursing care for a patient with CABG also involves caring for the surgical site, the chest, the arm, the leg. Care of the radial artery harvest site includes monitoring sensory and motor function of the distal hand. The patient with radial artery harvest should be on a calcium channel blocker for about 3 months to decrease the incidence of arterial spasm at the arm or anastomosis site. The care of the leg incision is minimal since endoscopic vein harvesting was used. The management of the chest wound, which involves a sternotomy, is similar to that of other chest surgeries. Chest incisions are usually closed with Dermabond and do not require dressings. Other interventions include strategies to manage pain, prevent venous thromboembolism by early ambulation and sequential compression devices. Prevention of respiratory complications would include use of incentive spirometer, splinting during coughing and deep breathing exercises. The past health history should include any history of coronary artery disease, chest pain angina, MI, valve disease like aortic stenosis, heart failure, cardiomyopathy, hypertension, diabetes, anemia, lung disease, or hyperlipidemia. Review the use of any drugs like antiplatelets, anticoagulants, nitrates, ACE inhibitors, other antihypertensive, lipid-lowering drugs, over-the-counter like vitamins and herbal supplements. Ask about a history of present illness. What's going on? Have them describe their current illness, including any self-treatments and response. Perform a focused physical assessment for the clinical symptoms listed on this slide. The overall goal for a patient with acute coronary syndrome include relief of pain, preservation of the myocardium, immediate and appropriate treatment, effective coping with illness-associated anxiety, participation in a rehabilitation plan, and reduction of risk factors. Phase 1 of cardiac rehab occurs in the hospital. It is important that the patient understand the reasons why activity is limited but not completely restricted. Gradually increase the patient's cardiac workload through more demanding physical tasks so that the patient can achieve a discharge activity level adequate for home care. Phase 2 of rehab begins when the patient is discharged home and continues for 2 to 12 weeks. Phase 3 is long-term maintenance for optimal cardiac health. Give the patient instructions on how to avoid or control precipitating factors. For example, teach the patient to avoid exposure to extremes of weather and eating large, heavy meals. If a heavy meal is eaten, instruct the patient to rest for 1 to 2 hours after the meal because blood is shunted to the GI tract to aid digestion and absorption. It's important to teach the patient and caregiver the proper use of nitroglycerin. Nitroglycerin may be used prophylactically before an emotionally stressful situation, sexual intercourse, or physical exertion, like climbing a long flight of stairs. Cardiac rehabilitation is the restoration of a person to an optimal state of function in 6 areas: physiologic, psychologic, mental, spiritual, economic, and vocational. Many persons recover from ACS physically, yet they may never attain psychological well-being. All patients, whether it's ACS, chronic stable angina, and cardiac surgery, need to be referred to a cardiac rehabilitation program. Teach patients to check their pulse rate. The patient should know the limits within which to exercise. If the heart rate does not return to the rate of resting pulse within a few minutes, instruct the patient to stop and rest. Also instruct the patient to stop exercising and rest if chest pain or shortness of breath occurs. The basic categories of physical activity are isometric, which is static, and isotonic, which is dynamic. Most daily activities are a mixture of the two. Isometric activities involve the development of tension during muscular contraction but produce little or no change in muscle length or joint movement. Lifting, carrying, and pushing heavy objects are isometric activities. Because the heart rate and blood pressure increase rapidly during isometric work, exercise programs involving isometric exercises should be limited. Isotonic activities involve changes in muscle length and joint movement with rhythmic contractions at relatively low muscular tension. Walking, jogging, swimming, bicycling, and jumping rope are examples of activities that are predominantly isotonic. Isotonic exercise can be a safe, steady load on the heart and lungs and improve the circulation in many organs. It's important to include sexual counseling for cardiac patients and their partners. This often neglected area of discussion may be difficult for both patients and healthcare providers to approach. However, the patient's concern about resumption of sexual activity after hospitalization for ACS often produces more stress than the physiological act itself. The majority of these patients change their sexual behavior not because of physical problems, but because they are concerned about sexual inadequacy, death during intercourse, and impotence. A concerned and knowledgeable healthcare provider could clarify the misconceptions held by these persons with specific counseling. Sexual activity for middle-aged men and women with their usual partners is no more strenuous than climbing 2 flights of stairs. It is helpful to consider sex as a physical activity and to discuss or explore feelings in this area when other physical activities are discussed. One helpful approach is, many people who have had a heart attack wonder whether they'll be able to resume sexual activity. Has this been of concern to you? Another is, if resuming sexual activity has been a concern, this information should be helpful. This type of non-threatening statement brings up the topic and allows the patient to explore personal feelings and gives the patients an opportunity to raise questions. The patient needs to know that the inability to perform sexually after an MI is common and that sexual dysfunction usually disappears after several attempts. Caution the patient that erectile dysfunction drugs are not to be used with nitrates because severe hypotension and even death have been reported. It is common for a patient who experiences chest pain on physical exertion to have some angina during sexual stimulation or intercourse. The patient may be instructed to take nitroglycerin prophylactically. It is also helpful to have the patient avoid sex soon after a heavy meal or after excessive ingestion of alcohol when extremely tired or stressed or with unfamiliar partners. Patients should also avoid anal intercourse because of the likelihood of eliciting a vasovagal response. In sudden cardiac death, there is sudden disruption in cardiac function, producing an abrupt loss of cardiac output and cerebral blood flow. The affected person may or may not have a known history of heart disease. It is often the first sign of illness for 25% of those who die of heart disease. Acute ventricular dysrhythmias like ventricular tachycardia, ventricular fibrillation cause the majority of cases of sudden cardiac death. Structural heart disease accounts for 10% of the cases. Patients in this group include those with left ventricular hypertrophy, myocarditis, and hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy is a risk factor for sudden cardiac death, especially in young athletic people. Approximately 10 to 12% of cases of sudden cardiac death among people less than age 45 occur in the absence of structural heart disease. These involve disturbances in the conduction system, like prolonged QT syndrome, Wolff-Parkinson-White syndrome. Persons who experience sudden cardiac death because of coronary artery disease will fall into 2 groups: those who do not have an acute MI and those who do have an acute MI. The first group accounts for the majority of cases. In this instant, the victim usually has no warning signs or symptoms. Patients who survive are at risk for another sudden cardiac death event due to the continued electrical instability of the myocardium that caused the initial event to occur. The second, smaller group of patients include those who have had an MI and have suffered a sudden cardiac death. In these cases, patients usually have prodromal symptoms like chest pain, palpitations, and dyspnea. Death usually occurs within 1 hour of the onset of acute symptoms. People who survive an episode of sudden cardiac death require a diagnostic workup to determine whether they've had an MI. Serial analysis of cardiac markers and ECGs are done, and the patient is treated accordingly. In addition, because most persons with sudden cardiac death have coronary artery disease, cardiac catheterization is indicated to determine the possible location and extent of coronary artery occlusion. PCI or CABG may also be indicated. Most sudden cardiac death patients have lethal ventricular dysrhythmias that is associated with a high incidence of recurrence. It is useful to know when those persons are most likely to have recurrence and what drug therapy is the most effective treatment. Assessment of dysrhythmias in these patients includes a 24-hour Holter monitoring or other type of event recorder, exercise stress testing, signal averaged ECG, and electrophysiological study. The electrophysiological study is performed under fluoroscopy. Pacing electrodes are placed in selected intracardiac areas, and stimuli are selectively used to attempt to produce dysrhythmias. The patient's response to various antidysrhythmic drugs is determined and monitored in a controlled environment. The most common approach in preventing a recurrence is the use of an implantable cardioverter defibrillator, also known as an ICD. It has been shown that an ICD improves survival compared with drug therapy alone, and drug therapy with amiodarone may be used in conjunction with an ICD to decrease episodes of ventricular dysrhythmias. Teaching people about the symptoms of impending cardiac arrest and the actions to take can save lives. Rapid cardiopulmonary resuscitation and defibrillation with an automated external defibrillator, combined with early advanced cardiac life support, has a high long-term survival rates for witnessed arrest. When caring for these patients, be alert to the patient's psychosocial adaptation to the sudden brush with death. Many of these patients develop a time bomb mentality. They fear the recurrence of cardiac arrest and may become anxious, angry, and depressed. Their caregivers are likely to experience the same feelings. Patients and caregivers also may need to deal with additional issues such as possible driving restrictions, role reversal, and change in occupation.